Daniel McCormick is with the Drug Enforcement Agency, and he's at a division here in Omaha. And he has been so patient waiting over there while we did our announcements. So I want to thank him for that, first of all. And so if you could all help me greet Daniel to the podium, and I know he'll give you more of his background.
Thank you. Oh, okay. Hi, can everyone hear me? I'm Dan McCormick. I'm the Diversion Program Manager for the Omaha Division of the Drug Enforcement Administration. So we cover Nebraska, Iowa, North Dakota, South Dakota, and Minnesota. But what I'm going to talk about today is kind of DEA's role. You've all seen us, and I think there's some misconceptions why we're doing things. And when we get into really the red flags, I'm just going to give you specifics. I'm going to go over a bunch of them, but I'm going to also give you some cases just I've worked. So they're just going to be, think of how many diversion investigators there are, and I'm just giving you examples of why I do it. And I think people get tired of us, and they're like, oh my gosh, why do we have to keep all these records? Why are we doing all this? And it really is, and I'm going to go into closed system distribution, but it really is to protect people. So the cases I'm going to talk about, there's deaths in every one of them. So that's really why we're trying to, when you get tired of us, that's what we're going to try to avoid, is those deaths. I'll say 98% of the folks that have DEA registrations do a great job. It's that 2% that go off and do crazy things that harm the public. So that's why we're around. So I know there's state rules. I'm not going to go into every state rule, obviously, so I'm just going to go over the federal rules. DEA is the same across the country, so our rules don't change no matter what office you're dealing with. All right, I got to do some legalese here. I have no financial obligations to you guys. I'm not getting paid to be here. This is just part of my job. We want you guys to ask us questions. We'd rather you call us with questions and issues, and we can fix it before it becomes a major problem. It's for educational purposes. No copyright infringements here. Everything I refer to will really go to the Code of Federal Regulations, my favorite book, and then that also goes to the United States Code, which is actually the legal code. Some of your CE things here. We're going to go over the Controlled Substance Act, describe some of the factors when placing substances in the schedules, we won't go that a lot. Explain the closed system of distribution. That's really the key. That's why you see us in your pharmacies asking you questions. That's why you see us coming out and doing the schedule investigations if you've been through one of our audits. We're going to go over some basics like, hey, this should be on a script, and you guys are going to be, oh my gosh, that's so basic. But we go out there and we find stuff is not on there. And we're going to go over some red flags and some things that you might want to double check. It's something fraudulent there. All right, I alluded to this. Controlled substance prescriptions are the fourth leading cause of deaths in the United States. So we have a huge problem. We've made a little, compared numbers. Last year we did a little better, but still we have over 100,000 people dying a year of drug overdoses. And controlled substances in the Schedules 2 through 5 are definitely part of that. Everyone talks about the fentanyl, the illegal fentanyl coming into the country, but the stuff we get in pharmacies, the 2 through 5s, are definitely a part of it, unfortunately. So really, we're going to be talking about prescriptions today. We're not talking about doctors administering or dispensing. So what is drug diversion? Real basically, it's going outside the closed system of distribution. It's going from the legal side, that the medical, being prescribed, being dispensed, being administered properly, or in a research setting, and going outside of that closed system of distribution and being illegally used. Little history lesson. So we've been around since 1973. We're different than other federal law enforcement agencies. We only have one law that we enforce. It's Title 21. It's drug laws, like FBI has a variety of things. DEA, we got one mission, and that's the controlled substances. Again, this is kind of cool. We got people from across the country. But I'm just going to be talking about DEA, and we're a federal agency, so again, so whatever state you go in, the laws aren't going to change for us. So DEA kind of confuses people. There's two parts to DEA. There's my part, the diversion part, and then there's the agent part. So everyone knows the agents, and they do the cool stuff. Everyone sees them going through doors, getting El Chapo and stuff. That's them. But my side, I always bug the agents, we do better stuff. Because hopefully most people have not seen heroin in their lives, haven't had to deal with someone with addiction to heroin or having crack cocaine or cocaine from Colombia. Terrible stuff. But we deal with all the drugs that have medical value. We deal with the 2 through 5s. So I tell the agents, you know, I go to most houses, I can't find heroin. I've been on search warrants, yeah, we found it, but most houses you can't. You go into most houses, what do we find in the medicine cabinet? We find a 2 through 5. When we look at addiction, where do most people first start their addiction? They get it from friends or family, and it's a 2 through 5. So that's the reason I think the diversion part is so important. And then people ask us, like, again, I know they get a little tired of us, and why do we have to do all this for our registration? Our funding is pretty interesting from the registration standpoint. We get no money from Congress for my section. Everything that we do is based off of the registration fees. So we don't make money. We can only hire people that we have registrations that pay for us. So we don't cost people any money. We are totally supported by the registration fees. Again, our whole mission is to make sure there's an adequate supply of controlled substances for medical and research needs. So we have a whole group in headquarters that does things with quotas, making sure there's enough drugs for medical needs and research needs. Sometimes the quota, whether manufacturers choose to use their quota or not, that's the manufacturer's decision. Again, it's a balancing act to make sure that we have enough controlled substances out there for medical use, but protecting the public from those drugs skating outside that closed system of distribution. Everything we do is based off the Controlled Substance Act. I'm not going to go through all these laws, but basically, drug laws have been around in this country for over a century. Really started in 1906. Many add-ons since then, but the Controlled Substance Act of 1970 is really the bedrock of what we deal with, what you guys deal with in the pharmacies. It places certain drugs into schedules. DEA works with FDA and works on the scheduling. It creates penalties based on the schedules. The registration documentation, that's where you guys come in with all the record keeping, whether it's the biannual inventory, the initial inventory, keeping the dispensing records, all working to get that closed system of distribution. Schedules are based on abuse potential. Schedule 1s have no medical value, so you won't see those in a pharmacy. And then the 2 through 5s all have abuse potential, but they all also have medical value. Everyone I think thinks of the 2s, the oxycodones, but all the way down to the 5s and the promethazine with codeine. The penalties range most severe for Schedule 1, Schedule 2s, all the way down to 5s. But I'll say you can't just go by a schedule and think, oh my gosh, there's no value. Unfortunately, you look at Schedule 5s, the promethazine with codeine. A lot of places won't carry it anymore because we have folks jumping over counters to steal it. And you think, oh my gosh, why does someone want cough syrup? I don't know who came up with this crazy idea, but you take promethazine, you get some 7-Up, you get some Jolly Ranchers, and you have a great drink called lean. I don't know whoever would think this was a good idea to start this, but it's popular on the street, and it's worth a ton of money. Those bottles on the street, it's gold to people. So that's the reason there's penalties for promethazine with codeine and other drugs in the 5. There is a value there's abuse and there's a value on the street for them. So how do we do this closed system of registration? Anyone that needs a DEA registration has to get it, and that's basically anyone that handles controlled substances. And once you get that registration, you have specific reporting requirements with us, you have specific record-keeping requirements. Over 90% of the DEA registrations are for practitioners, whether they're doctors, veterinarians, dentists. But researchers have them that use controlled substances, and then corporations like manufacturers, distributors, exporters, importers. Pharmacies are kind of unique. You think of all the controlled substances going through there. Pharmacists don't have a DEA registration. Techs don't have a DEA registration, but the pharmacy itself has a DEA registration. And why do we do it? We do it for the closed system of distribution, which I talk about, and I've talked about it already. So basically, with this registration system, from the time a controlled substance is imported, manufactured, goes to the distributor, the pharmacist, researcher, through the record keeping, we can follow that controlled substances. That's what the diversion group does. So we want to follow that controlled substance through every registrant till it gets to that end user. So the pharmacies, you're at the tail end, that it's going to get manufactured, then it's going to go to the distributor, McKesson, ABC, whoever it might be. Doctor writes a script, you give it to the end user. We want to be able to follow that till it gets to that end user. All right, roughly 2 million DEA registrants in the country. So there's roughly 800 of me out there. So people think we're targeting individuals. We're not. We don't have the ability to do it. And just roughly 65,000 pharmacies in the country that have DEA registrations. So really the closed system of distribution just does not work without every registrant following the rules. All right, so we'll get into some commonly diverted controlled substances, talks about some red flags, and then a few things that can help you prevent a diversion. All right, you guys all know these drugs. Oxy, obviously, big deal still. A lot of the methylphenidates, a lot of those type drugs, very popular now. And again, you guys, you think about, you see what you paid from the distributor. It's, wow, that bottle didn't cost too much. On the street, these drugs, it's a whole different thing. So I can take an Oxy 30, and if I'm a terrible salesman, it's basically $1 a milligram. So that pill's $30. So if I get 90 of them, I'm doing pretty good. It's not that hard to go out on the street and make money. Again, all of these have a street value. The promethazine with codeine is thousands of dollars a bottle. So this is where pharmacists have a responsibility. And again, you guys working with the pharmacist, the responsibility for proper prescribing dispensing of controlled substance is upon the prescribing practitioner, but a corresponding responsibility rests with the pharmacist who fills that script. So what does that mean? So if we can show that that doctor is right outside the course of professional practice, and that pharmacist fills that knowing that, they can be charged criminally too. So we don't want to charge people criminally. We'd rather get people in line and not have to. But when people go so far outside the lines, we have to follow, we have to. And I'm going to have some examples of where, just one case that I did where both the doctor and the two pharmacists were arrested and convicted. To be a real script, it has to be issued in a legitimate course of medical purpose and must be issued in the usual course of professional practice. In the usual course of professional practice, this becomes an issue. I don't know why, but it becomes an issue. A veterinarian cannot write for a human, ever. I don't know why. This comes up a lot. Yeah, so this comes up a lot. A dentist cannot write for someone's physical ailments outside. If it has something to do with their practice, they can do it. But, they're not psychiatrists. They can't be running 2 practices there. So it seems like a simple one, but that one comes up all the time. And what's funny is I go talk to vet schools, and I have to really get that across to them. All right. So just some red flags. Let me go back here. Again, I'm going to refer to some specific cases. Patients with common factors, same prescription from same doctor for controlled substances. I will talk about one of my doctors. He would write for 560 oxycodone for everybody.
The number 5?
Yeah. So again, I want to use, the cases I'm going to use, they're not borderline. DA, we never go to a doctor and say, hey, you should have written for 52, you wrote for 60. The numbers, you can decide if they're crazy. I'm going to say 560 is crazy, every 2 weeks. So he would write 560 every 2 weeks for everybody. It was a really easy trial in the sense that all I had to do was show the patient files, because he would keep the scripts in his files. So it was pretty easy. We had 7 patients that we used. We could have used more. And he happened to use one pharmacist all the time. They all went to this pharmacist because there happened to be a drug ring that started to use him, because they knew they didn't have to do anything to get the 560, and they'd always go to this drug ring. This drug ring would then go and use this one pharmacist. What was sad is we take down the one drug ring, and she tells us, the bad pharmacist, he doesn't know what he's into. He was working with another drug ring that was bringing him bad scripts. And she goes, they're really dangerous. And we were talking to her, and it's like, well, I think you're pretty dangerous, because her and her girlfriend ran the drug ring, and her girlfriend was out of prison now, but her girlfriend had just murdered someone. And she thought the other drug ring was bad. So I'm like, the pharmacist was in cahoots with both of them. So it sounds crazy, but if you see 560 every time from one doctor, that's a red flag you should be able to pick up on. Someone coming in, picking up scripts for like 10 people. That should be a red flag. I get it. Every case, there could be a reason for it. Maybe it's a nursing home or group home. There could be a reason, but follow up on it. There could be a very legitimate reason. But if they come in every week, 10 different names, and have out-of-state plates, that's a red flag. Unfortunately, you've all dealt with erratic patients, seem high, threatening. Again, that's a red flag. Double check that script, call the doctor. Patient travels long distance to fill the script. Again, there might be a legitimate reason. There might be a specialist right there. Makes sense. But worked in a different city, 3 million people. We had a guy that drove over 50 miles to see a general practitioner. Now, we started to put the case together, and I started to put how many doctors he passed, how many pharmacies he passed. It didn't make any sense. So we just gave up because it was too many. And the doctor would tell the patients where to go fill the scripts. Only one pharmacy in that area would fill his scripts. Another sign that we'll talk about. So this guy was going over 50 miles. Very sad case. He was involved in a bike accident. Worst luck in the world. He picks the worst doctor in the world who just writes anything, gets him addicted. We have his medical file from the ER doctor. He overdosed, and the ER doctor literally wrote in the script, I'm paraphrasing, but literally wrote, dosages this high will not work for a long-term life. 6 months later, he ODs and died. So going to one doctor, 50 miles away, one pharmacy. This pharmacy had 7 people that committed suicide from this one doctor. So again, that should be a red flag. Patient pays cash versus insurance. Again, I'm not saying that's always illegal. Sometimes it just happens. But follow up on that, because most people have some type of insurance. If they're always paying cash, sometimes they're trying to avoid their insurance finding out about it. So, or if they want to put certain things on insurance, certain things on cash. Again, there could be a legitimate reason, but it's a red flag. Follow up. Patient frequently loses medications or requests early refills. All right, again, it happens. Does it happen continually? Probably not, hopefully not. So I have a fellow, he lost his medication, over 500 dosage units, swimming in the ocean. So, okay, I don't usually take my pills in my trunks and go out, but everyone gets a call. So he loses his medication, but he was getting 540 oxy-30s at a time. So we're better than 560, so we've improved. So he goes in, and I wrote down the date. So he goes in on October 23rd and gets his 540. So he gets his month's worth on the 23rd. He then goes in on the 30th, says his wife and him are getting a divorce, so he's losing his insurance, and the pharmacist give him 1620 in one shot. So that, you don't even have bottles there for that. Most people don't. So actually, the distributor was there. They brought him more. So there we got 4 months supply in, 1 week, basically. And then he comes back in December, and they give him 760. So again, we follow up on this. Those are red flags. Those, I don't think they should be tough to catch, but everyone looked the other way. And so there's ultimately conviction there. Prescription looks altered or too thorough, lacks common, it doesn't have the bid, doesn't have the common abbreviations you see. All right, extreme example. Why would you fill a script with whiteout on it that you didn't? Okay, I get doctors make a mistake, but if you fill it out and it has whiteout on it and you fill it without calling the doctor, that's inexcusable in my mind. Really basic stuff, but it happens and we can stop it. Prescription quantities, directions are different than normal medical usage. Again, just follow up with the physician. If you see, the physicians in your area, you're working with them, you get kind of used to what they're writing, and then someone comes in with something from that physician allegedly that's totally off the wall. They always write for 30, they always write for 25, and they come in with 22. A lot of times they're going to put lower numbers thinking no one's going to look at it. Follow up on those that seem outside what you're used to seeing. Prescription information is not correct. Name of doctor, address, phone number. Okay. How you've been dealing with this doctor forever, and their name is wrong on the script, that should be a red flag. And I'm always saying call the doctor, call the doctor. It's more difficult now, I'll say, puts more with ghosting of numbers, it is tough. But if you call and you can never get through to the doctor, that's a red flag. But follow up, show that due diligence, put it in the profile that you followed up and made that effort. Large quantities of controlled substance. That we've talked about some numbers. Going back, another one of my patients, this is January 3rd of 1 year. She came and got 200, and one doctor wrote this, one pharmacy filled this. 270 morphine IR 30s, 127 morphine ER 60s, and 120 morphine ER 100 milligrams. But she got more than that. I just listed the morphine for this. Then she comes back in January, the 17th, so that was the 3rd. She comes back the 17th, gets 270 more IR30s. You know, she just gotten those on the 3rd, and then she comes back the 23rd and gets 450 of them. So in January, she got 990. And that's just the morphine. Again, I'm saying look at high numbers. That you should be able to pick up upon. And I'll say this is the saddest case. It's sad, but there's also some goodness to it. So she was actually working in a doctor's office. And but he was writing the scripts. She'd write some. We interviewed her, and she's done a great job. She went back, she got herself into counseling, she got into rehab, and she's doing well now. We interviewed her. It's the only time I've interviewed someone, they call it a proffer. You go in front of the attorney, and you're like, they have their attorney, they'll give up information and hopefully get a lighter sentence. Usually it's talking to them directly. We had to have her husband come with her because she was so addicted for such a long period of time, she literally cannot remember certain things. She would have to bounce it off her husband. And again, she went to rehab, doing much better, but how can you have 900 of one drug, the IR30s, and that's not even counting what else she got, and that pharmacy just let it go. And it was sad. That was the pharmacy, that doctor had 7 suicides, and we were talking to the tech at that pharmacy, and she was talking about, oh, how nice some of these patients were, and she knew about all the suicides, but they continued to fill. Patient requests controlled substances to be filled. They want the schedules, but not the non-controlled. So if they come in, they got Oxy 30, I always use Oxy 30, and the doctor wrote some heart medication. If all they want's the Oxy 30 and not the heart medication, that's a sign. All right, so as I talked about that patient that went the long distance, the patient that was getting all the morphine, the IRs, and the lost medication, those all went to one pharmacy. Well, these 2 guys own 2 pharmacies, but they knew what they were filling for all of these people. And no one else in town would fill for this doctor, but this pharmacy, they would. So eventually the doctor's convicted and both pharmacists. And what was really sad, and I don't think he was giving us a hard time, talking to the pharmacist, he is like, we'll be pretty upfront, how could you fill these? Did you ever follow up on it? And he said yes. And he was convinced if he called the doctor and the doctor told him he wrote it, it wasn't fraudulent. So he could go ahead and fill it. And I'm like, well, why did you go to pharmacy school? I mean, if you don't have any responsibility, that is not that's not your corresponding liability. You have a responsibility, and he had been a pharmacist. His grandfather had been a pharmacist. His dad was a pharmacist. He was a pharmacist. He was in the 50s by then, and he literally thought, I could just fill it if the doctor says it's okay. And again, we brought up no one else in town's filling this guy's scripts, and you are. And all of these were examples coming out of his pharmacy. So his techs saw the scripts, he saw the scripts, and it all got filled. So, all right. As I said, call the practitioner. Check with them. And again, some pharmacies, they won't fill for certain doctors. That's fine. If you think they're out of bounds, don't fill for them. Advise other pharmacies. It's always great to me when I go talk to a pharmacy and, you're talking to the tech, they're like, yeah, we don't fill for them and they don't fill for them. Or I go in there, we're doing an audit and it's like, yeah, this doctor, their stuff doesn't make sense. That's helpful. Contact your state board of pharmacy. Call us. Again, we'd rather have issues stopped early than them growing out of control. Just some things within the pharmacy. The well-defined policies and procedures, store the controlled substances properly. access and complete records. Again, we're going to come through, we're going to do the audits, make sure you have the complete records. One of the things, the policies that is easy but gets overlooked, one person ordering the controlled substances and receiving the controlled substances leads to problems. So mix that up, who's ordering, who's receiving. Always have two people receiving and mix it up. Had some techs, they got to do all the receiving all the time. So they just started taking bottles and handing them out, literally handing them out the back door. But then, when they start telling everyone and showing up in brand new vehicles that they paid for in cash, that raises some red flags for us when people call us. But they literally were just taking it from the totes and taking it outside the door and selling. Diversion awareness training, reporting. We want to get people help. If someone has an addiction issue, they're working in the pharmacy, there's places they can get help. There's state boards, get them into help. We'd much rather them get the help they need for their addiction, get healthy, and not hurt patients. So sometimes people are like, I don't want to report my friend. You're helping your friend. Get them the medical help they need, and you're not harming patients. Regular audits of controlled substance records. Again, our records, you got to keep all your records for at least 2 years. You got to do a biannual every 2 years. You can do it more often. There's nothing wrong with doing it more often. So I say, especially with today's technology, do it more often. And then implement some basic security with cameras. It's not that difficult. Just some things we can do if there are problems with the registration. We can do a letter of admonition, and you probably see that after we come out for do a schedule investigation. And basically, we send that out to the registrant and say, hey, we know you're trying, but you're not following quite all the rules of the CFR. And what are you going to do to correct it? You guys just write back and say, hey, we're going to follow the rules here. Memorandum of agreement, those are a little more severe. We actually say, you're trying, but you're really messing up. So you're going to take what's in the CFR, you're going to follow everything, but we're going to add some more reporting requirements or more rules for you for a certain period of time to see if you can get your act together. Certain cases, there's civil fines. We can go to the U.S. attorney. Basically, record-keeping issues. Let's say I don't fill out my 222 correctly. Every violation's a little over 16 grand. So when we go 2 years worth of records, we can come up with a ton. So we can go to the civil fine. Order to show cause, we actually take registrations from people. And it goes up through an administrative judge. And immediate suspension order, we take away the registration and then go to the administrative process with the administrative judge. And the most severe, the one we don't want to, but if it's public safety, we're going to, is the criminal prosecutions. Okay, this got a little out of order. Prescriptions, to be effective, again, must be legitimate medical purpose, course of professional practice, and just make sure these things are on there. I mean, if we come out and do an audit and these things aren't on there, it's a violation of every script. And again, these are pretty basic. Have the date and signed. And again, the CFR says signed like a checkbook. I mean, that's pretty easy. Name, address of patient and practitioner, along with the registration number of the practitioner. I'll say this is difficult at some pharmacies, and I get it. You get the physician that comes in with 14 DEA registration numbers on their script. There is no regulation that we can stop that, unfortunately. I know it's difficult, but sometimes not all the DEA registrations are valid anymore. So they fill it under the wrong DEA registration number that isn't valid, so that's a violation. Plus, you're putting that into the PDMP in most states, so avoid that. Again, include drug name, strength, dosage form, quantity, directions for use, and authorized refills if it's a 325. DEA doesn't require the code saying, hey, this is back pain or whatever. A lot of doctors like to put it on there. That's great, but there's no requirement from the DEA on that. All right, my time is about up. And I'll also say, every state, use your PDMP. And I know every state has different regulations on it, but just use it. It's a great tool, and there's no reason not to use it. So, All right.
Okay, when I double check like the Schedule 2 narcotics is one of mine, can a post office box cannot be on a Schedule 2 drug, can it? Doesn't it have to be a physical address, or can they use a post office box, the patient?
The patient, yeah, you can mail that, yeah, so it could be,
Like on the script, can it have a post office box? Or does it have to be a street address?
it could be a post office
It
box,
can
yeah.
Okay.
And again, states can have different, so I don't want to get into
Okay, that's
states.
fine.
Ours just says you have to have an address, and it doesn't go that specific, so.
So you just mentioned that there's no regulation on how many DEAs are on prescription, like why? Who changes that?
Yeah, me complaining to headquarters. Yeah, I'm just gonna guess on this. I think when they originally,
The name dog, the favorite dog is like a hard boxer. It's just a big dog.
Can we tell them to mute? It's somebody from the.
I don't think so, they're all muted. I'm sorry. I
Oh.
don't know, and they actually don't have sound now, there's something going on, so I'm sorry.
oh, no. Yeah, I just assume when they wrote the regulations, they really didn't think of that. But it's something I complain about, because I think it would be easier for you guys, and it'd be easier for us. And so I think, because that is really tough, and I'm just thinking, because we just recently had a case, and I think he had 7 DA registration numbers on it, because, they get it for different places that they practice, which, they're supposed to, so that's good. But yeah, it's very difficult.
I have a question. I have a background in disaster preparedness. So when you said a vet could not write for a person, I was trained that in a disaster, they can.
I've never heard that.
I actually have.
Okay.
I actually have. Maybe one time I've heard that. It was in the event that there was a disaster.
Disaster that a vet can write. Like if I need a distribution for doxycycline in a massive event, I can get a vet. If that's all I can find, I can have a vet write a script for a person.
Okay, yeah, I've never heard that, but, and I gotta say, unfortunately, we've had some tornadoes here lately. I mean, when there's natural disasters, we definitely work with people. We don't want people not to get their controlled substances. So we could do some things like when there's disasters and stuff, and unfortunately, we've just had that issue here,
There's a
so.
lot. I mean, I'm sure everyone's, thank God we don't get many enough, or, where
But,
it's not.
but like if we have a massive avionic flu and we have to go to a mass distribution, I have to have a pharmacist on site and a provider. And if all I can find is a vet, he fills the slot. Because we've done exercises. Not oxy, but, antibiotics and stuff.
Yeah, and remember, like, non-controls, we don't have anything to do with. Yeah, we don't go there.
I have a question. So, I do med histories and we have to refer to the PDMP all the time. We have several patients that come from Council Bluffs, Iowa. So our PDMP does not cross state lines. Why is that?
And some do, and PDMPs are state, every state runs their own, they're not federal. So that's the reason some states talk well with each other, some don't. It's just what the states decide to do. There's been, again, it's a state thing. I guess if there was ever a national PDMP, that wouldn't be an issue, but right now, every state does their own thing, so.
So for the state PDFPs, for like these cases that you're bringing up, so do they alert you guys in some way, shape, or form? Like,
Again, every state kind of does it differently. In that particular case, the state did not. They didn't have a way to do that they would. And again, states, their programs evolve over time, but at that point, they weren't doing that.
so how do you receive your like notices and alerts and all?
A lot of it, we don't really get PDMP notices.
Okay.
But a lot of it, again, is we go out, we do audits in a lot of different places, pharmacies, distributors, and with that closed system of distribution, we really try to see where the controlled substances are going. And again, when you got, I'm just gonna say, a lot of the places I've worked have been kind of rural, and you got that rural pharmacy that's getting 4 times what they're getting in the city, we go out, and there might always be a legitimate reason, but we go out and check out why, and hopefully it is legitimate, but sometimes it's not.
So you're kind of alerted when a pharmacy maybe is in the ordering process. So if they're ordering more then it's kind of like, let's start tracking what's going on here.
Yeah, sometimes we do that, and frankly, when you're as old as me, you've been out there on the street so long, I get folks that call me, from pharmacies. I get texts and pharmacists that'll say, this does not make sense. And that's great. And again, we follow up, and sometimes there's a very legitimate reason, and sometimes there isn't. All right, thank you.
To recognize you in some way.
Oh,
and
thank
then
you.
I thought you could take criminal notes on there.
Okay,
Thank you. Thank you very much.
You bet.
Very